Chapter 21, Control of Respiratory Function. This is an overview chapter. You don't really have to listen to this lecture unless you want to review the anatomy and physiology of normal respiratory function. So basically the function of the lungs is to exchange gas. It moves oxygen into the blood and removes carbon dioxide from the blood. A lot of vasoconstricting substances are involved in this process. Not that you need to remember this. Think of the upper airways as the movement of air between the atmosphere and the lungs, which is the process of ventilation. And in that process, in the upper airways, the air is filtered, warmed, and humidified. Upper airways, nose, mouth, pharynx, larynx. This is where we're humidifying and filtering the air. In terms of upper airway blockages, because of trauma or tumors or foreign objects, it leads to a blockage of the intake of this air, where you will have hypoxemia, lack of oxygen in the blood, and hypoxia, which is a lack of oxygen for the body. Both of these conditions, if total blockage occurs, will result in loss of consciousness and death. The lower airways, which would be the trachea, bronchi, bronchioles, is where gas exchange occurs. There's multiple defense mechanisms here. You have your irritant reflex, which is a bronchospasm and cough when irritation reaches the bronchioles and bronchi and tracheae, and the lining of the tissue creates an irritant and a cough reflex. You have the mucocilial system, which is the mucus to trap particles, and there's a certain amount of secretory immunity that takes place there, where antibodies initiate the immune response. Diseases that affect these airways are blockages of inflammation, tumors, foreign bodies, bronchospasm, or trauma. In the respiratory tissues, mainly the alveoli, this is where gas exchange takes place. These alveoli are very fragile. They can be damaged, and once they've been damaged, there is no regeneration. Surfactant is the key fluid that keeps these sacs open and viable, like balloon-like. And there are macrophages that live in the alveoli to keep substances out. The way that our pressure gradients in our body are set up is the pressure gradient is set up for air to move into the lungs, which is interpleural pressure is always negative in relation to the alveolar pressure. Compliance is a concept of how easily the lungs can be inflated, and it depends upon the elastin and collagen fibers of the lungs themselves, how much surface tension, surfactant, and water content is present in the lungs, and the flexibility of the thoracic cage. Normal compliance is about 200 milliliters per centimeter of water. As you age, this compliance of the thoracic cage and the ability of the elastin and collagen fibers to expand and contract gets compromised. So as a normal feature of aging, your respiratory mechanisms become more stiff, and you have a decrease in surfactant and water. Other diseases that affect the compliance of lungs would be your interstitial and pulmonary fibrosis, pneumonia, CHF, particularly pulmonary hypertension, emphysema, which would be an overstretching of those alveoli. Know that coughing and deep breathing helps spread that surfactant to open up your airways. And if we don't have enough surfactant present in the lungs, the alveoli collapse, which is what happens in premature babies. Key diseases of the processes of the airway result in either hardening of the elasticity of the lungs or the thoracic cage, or decreasing the surfactant or the ability of the lungs to inflate. So ventilation perfusion mismatching, or just normal ventilation and perfusion, is about how much air gets into the alveoli. That would be ventilation. And how much air gets into the blood in the capillaries is perfusion. For effective gas exchange, these two must match as closely as possible. So in a normal, healthy adult, the VQ ratio is 4 to 5. In diseases where ventilation and perfusion are mismatched, meaning either you have ventilation without perfusion or perfusion without ventilation, that means that oxygen is not being picked up by the capillaries and delivered to the tissues, and this resultant oxygenation at the tissue level is what we call hypoxia. Ineffective gas exchange ultimately affects all body systems. There are usually 3 causes of this mismatch of ventilation and perfusion mismatching. Either we've got shunting of non-oxygenated blood, which would equal perfusion without ventilation. So think of things like atelectasis or anything else that reduces the ventilation to the lung. We can have an increase in dead air space, which is basically ventilation without perfusion. And things like a pulmonary embolism or disorders that decrease cardiac output result in this kind of a mismatch, which essentially reduces perfusion to the lungs. And then we have like a silent kind, such as pneumothorax or acute respiratory distress syndrome. You've got total mismatch in the body. The normal value of oxygen in the blood is about 80 millimeters per hemoglobin, and oxygen is bound to that hemoglobin in order to be distributed to the body, and we call this the oxygen hemoglobin dissociation curve. Normal values result in a 95 to 97% saturation rate. You do not need to memorize the oxygen hemoglobin dissociation curve. You'll talk about that more probably in critical care, but you do need to understand that if the hemoglobin is reacting properly and carrying oxygen, that the normal value of oxygenation is about 95 to 97 saturation rate. So that O2 saturation rate is measuring this amount of saturation, that the capability of the body carrying oxygen. And last but not least, this is just a great visual of the normal respiratory process. Know that the respiratory process has autonomic and voluntary components. Um, in the autonomic system, chemoreceptors, um, which sense the amounts and levels of oxygen and carbon dioxide in the blood, and also sense the pH of the blood and increase or decrease respirations accordingly. And then there are lung chest wall receptors that are more related to the resistance and ability of the lungs to expand. In terms of the voluntary process, we use this when we speak, sing, where we are causing temporary suspension of autonomic breathing processes.